Welcome, everyone. My name is Dr. Adam Abadili. I want to thank the CBD Live for putting this event together. It's great to be able to connect with people and to network, particularly in these challenging times of COVID. I also want to thank our audience and participants who are joining us. My understanding is that this event will be recorded, and this talk will be recorded, and hopefully you'll be able to access it if you haven't had a chance to see it or would like to refer back to it. But I'm going to be sharing with you today lot about myself, as well as a lot about gut health, gastrointestinal disorders, and the case for cannabinoid therapies. I will point to you that I have my email address here on this slide. If Feel free to reach out to me via this email. I'll also include this in our final slide at the end of the presentation. If you have any questions or want to connect, feel free to reach out to me at the email address. Might just give me a day or two if I don't respond, or keep pestering me. So briefly about myself, I'm a U.S. based surgeon. I'm board certified. I hold board certifications in both general surgery as well as gastrointestinal surgery. And I specialize in the medical and surgical treatment of gastrointestinal conditions and malignancies. And this is really the reason how I stumbled upon cannabis as an option for patients. Over the past 8 to 10 years, I've been working with patients who are interested in utilizing medical cannabis. I also learned early on that a lot of my patients who were treating themselves with with cannabis for a variety of different cannabis for a lot of different GI conditions. So we opened up a medical cannabis practice here several years ago, and even prior to that, because it was illegal before that, I was providing education for patients and some general guidance for them on how they might effectively use cannabis. In addition to that, we also have a unique opportunity to be located up in an area where we have a lot of professional athletes, including Olympic athletes that we work with as well, which has been a very interesting venture, particularly given the THC limitations that a lot of these professional athletes, have to be cognizant of. Some of my other interests is in clinical research. We are currently doing clinical research trials on patients with inflammatory bowel disease and other GI conditions, particularly looking at markers and modulators of the endocannabinoid system. In addition to my medical practice, I also have several other interests in the cannabis industry. I'm a co-founder and chief medical officer of a supplement company called Reserve MD. We also manufacture and formulate CBD-based products. I also enjoy education in this space, because without education right now, it is very difficult to gain acceptance and traction and really understanding of cannabis. And until you understand how cannabis works, and you understand our human body and the endocannabinoid system, it's impossible to discuss cannabis-based therapies. So I'm currently the director of medical education for the Cannabinoid Medicine Studies, which is affiliated with the Cannabinoid Industry Association. You can visit us online, and we offer multiple different courses. Some of them I've hosted myself, and other I've recruited several other industry and world leaders in their respective fields. Just recently, I took on the role of position of something I'm very excited about, as the CEO of Coral Cove Wellness Resort. This is a 4-star resort in Jamaica, and you can probably see by the picture here, it's a beautiful, picturesque resort on the southwest region of Jamaica. And this is going to be a really special resort and retreat for multiple reasons. As I mentioned, it's a 4-star resort that is cannabis centric. And like several other resorts, there are spa facilities. There's obviously a beautiful, picturesque region. The ocean is beautiful in multiple different ways to enhance wellness. But really what sets us apart is that we are the first and only resort of our kind that also has a cannabis and psilocybin research institute associated with it. And we drive a lot of the information, experience, research that comes out of this research institute on cannabis, psilocybin, but also many other natural-based therapies to actually drive the wellness experience for those who are coming to the resort for wellness experience. And we have our on-site grow cannabis grow site as well as a dispensary as well. So so moving on, I want to share with you, what I want to be able to relay to my audience today. And this is when we talk about the endocannabinoid system and cannabinoids for GI health, we have to understand that this is an enormously large topic. And my goal today is not to give you all the details, but I want to provide about like a 30,000 foot view, if you will, of what cannabis is, what the roles of cannabis in GI health are. I will be talking about some specific cannabinoids, but I really want to give you a global picture of where we are, particularly knowing that we have a relatively diverse audience listening in. So briefly for the agenda, I'm going to talk very briefly about the history of cannabis for GI purposes. I'm going to share with you the discovery and components of the endocannabinoid system with relationship to the GI system, talk about how our natural endocannabinoids interact with the endocannabinoid system of the gut, but also how the synthetic cannabinoids, but most importantly, how the plant-based cannabinoids, what we call phytocannabinoids, the role that they play within our gut. I want to share with you where the clinical relevance of these interactions may be, talk about future directions for cannabinoids and gut health. I want to emphasize that things that we won't be discussing today will be the role of the gut endocannabinoid system and cannabinoids for metabolism, but also for the roles of our microbiome and the interaction with that. Those are I've given talks on those, and those talks in and of themselves are very lengthy talks, as all the individual topics that we'll be discussing in this presentation. So I want to just kind of give a nice broad overview. We're probably all aware of the fact that that medicine, that cannabis as medicine is not new. It's been around for thousands of years. Originated in China. As a surgeon, I was particularly interested in it when I learned that cannabis was one of the earlier preparations used for anesthetic agents for different surgical procedures. It's also been reported in the literature that in the Old English Herbarium book that was published during in medieval England, that cannabis was used for conditions of the GI system. And in the 19th century, cannabis was actually one of the first documented clinical treatments for infectious diarrhea. And this came in the form of tinctures in the 19th century. Unfortunately, in the 20th century, cannabis started to lose out to Western medicine, if you will, and kind of conventional pharmaceuticals. And I think that this was a big disservice to the health and well-being of us as a society. So cannabis is not, the reason I included this slide is that it shows some science that was published back in 1998, and it was in the 1990s when we first started to discover that the cannabinoid receptors and the components of the endocannabinoid system were well and alive in the GI tract. But importantly, similar to the way that we've discovered cannabis and how it interacts with our body, we actually learned how cannabis affected people long before we understood how it actually affects people and how it works physiologically. And in fact, in 1974, was when we first had studies showing how THC actually interacted with our gut and slowing motility. Throughout history, cannabis has been used for multiple conditions, and these are really the same conditions that we're looking at them for now and utilizing them for: nausea and vomiting, different infectious gastroenteritis, diarrhea, inflammatory conditions such as Crohn's disease or ulcerative colitis, peptic ulcer disease, as well as hemorrhoids. And then I'll probably throw in there cancers and chronic abdominal pain as well. And although I say that I've been practicing cannabis-based medicine for 8 to 10 years, I actually, had thought about it recently that I've actually been practicing cannabinoid, if you will, or endocannabinoid-based therapy for much longer, that about 20 to 25 years, because I've been prescribing in the U.S. There's a pharmaceutical agent known as Dronabinol, which goes by the trade name Marinol, which is approved in the United States for chemotherapy-induced nausea and vomiting, as well as anorexia and weight loss associated with AIDS patients. So I have utilized Dronabinol for what's going on 20 years now for cancer patients for anorexia and chemotherapy-induced nausea and vomiting. So in order to gain an appreciation of the endocannabinoid system and how cannabinoids can help us, I want to just start by just giving you a little bit of brief background on the anatomy and function of the human digestive system. A lot of people think of the digestive system as simply our intestines, but there's actually several organs which comprise our GI tract. If you think about, when we start to consume food, it starts in our mouth and it goes all the way until it comes out the back end. And so if you look at, even digestion begins in our mouth, and within there we have saliva glands and different salivary glands. And these glands are influenced by the endocannabinoid system, and therefore will be influenced by any sort of cannabinoid receptor modulators, such as the plant-based cannabinoids. But in addition to if you look at the GI tract itself, you have the esophagus, the stomach, the small intestine, and the large intestine, but there are several other crucial organs, including the liver, the spleen, and the pancreas, just to name a few. And the job of the digestive system is not to just digest our food, but it's involved in detoxifying, eliminating waste. It provides immunity. We have to remember that about 80% of our entire immune system is located within our gut. And that is because our gut is really one of the primary introductions of pathogens. When we consume food, none of our food is sterile. So what we consume, we have to make sure that it's safe for us. And if not, the body has to have the ability to eliminate or defeat some of these potential pathogens, whether they be bacterial, viral, or even environmental. And then, of course, the GI tract also plays a role in metabolism. And if you look at the GI, the GI tract itself, meaning the intestines, the way I like to describe it to my patients is that you think about the GI tract as being a long tube of muscle that goes from one end of our mouth all the way to the other end. And that tube of muscle, its job is to do a few things. One is that its main job is to propel food, what we call peristalsis, to move stuff through our GI tract. But it's also involved in absorption of our nutrients. And so if you look at this, the tube, if you will, of the GI tract, it has to be supplied by blood vessels. It has to be supplied by nerves. And then there's immune system cells within it. There are glands in it responsible for a host of different conditions. And what I want to point out is that in every section of the GI tract, the endocannabinoid system is well and alive. And if you look at the inside of the lining of the GI tract at a closer level, if you could, this is the picture that you would see. It almost looks like a carpet, if you will, and that is because the inside lining of our GI tract is made up of these little finger-like projections called villi. And the whole idea of these villi is to increase the absorption area of the GI tract. And if it's estimated that the entire surface area of the GI tract, if you were able to lay this out, is about the size of a tennis court. Not sure if that's a singles or a doubles tennis court, but nonetheless, it's still a lot of surface area. So I want to share with you some of the cannabinoid receptors that are in the GI tract. And the most common prevalent cannabinoid receptor, because it's been studied so heavily, is the cannabinoid type 1 receptor. And if you look at where this is located, it's located throughout the entire GI tract, not only in the intestines themselves, but also the organs that I mentioned. The CB1 receptor is found predominantly in the excitatory motor neurons. So these are the neurons which control motility, but they also are the nerves which are responsible for controlling secretion of the glands of our gut. The CB1 receptors are found in the cells of the gut called epithelial cells, and they tend to be most heavily concentrated in and around our nerve cells, whether they be motor cells, which control function, or sensory nerves, which help transmit pain signaling. And so, as you know, globally, the CB1 receptors modulate intestinal motility, pain, and secretions. Now, they have served many other roles as well, but those are the big ones that I want to emphasize in this talk. The cannabinoid type 2 receptors are also found within the GI tract, entire GI tract, and they're found much more densely concentrated within the cells of our immune system. And this is what we've learned about the cannabinoid type 2 receptor, is that one of its biggest functions is its role that it plays in immunity and inflammation. And although it's predominantly found in cells of the immune system, it is also found in a lesser degree in the nerves. What is interesting, and I'll talk about this again in some upcoming slides, is that this CB2 receptor during times of stress, injury, or inflammation actually gets upregulated. So that again emphasizes its important role that it plays in stress, injury, and inflammation. There are a host of other cannabinoid receptors. We're learning more and more every day, but just a few else that I want to highlight, because as we start to look at, therapeutic modalities using plant-based cannabinoids or synthetic cannabinoids, the targets of these molecules oftentimes is based on these receptors. A lot of the therapeutics are also focusing on looking at the enzymes which are responsible for making our own natural endocannabinoids in our body. And then there's a lot of research also looking at the enzymes which are responsible for breaking down our natural endocannabinoids, as well as breaking down the plant-based cannabinoids. But some of the other receptors that are worth noting are, the first one is being the TRPV receptors. We call it transient receptor potential vanilloid receptors. And TRPV1 is the most prevalent of these. It is found in what we call the myenteric plexus, which is the nerve plexus of the GI tract. And it's been shown to be involved and important for what we call visceral hypersensitivity. And what visceral hypersensitivity is the pain that is transmitted from our GI tract. And this TRPV1 receptor also has been found to assist in regulating secretion and motility. There's also another group of internuclear enzymes called PPARs, or what are known as peroxisome proliferator activated receptors. And these are, as I mentioned, internuclear receptors that are found within the cells of the small intestine. And we're learning that they're playing important roles, or have potential to play important roles in metabolism, cancer, and inflammation. We have some other novel receptors. We call it GPR55, GPR119, and there's several other G protein receptors that are being studied that have multiple roles. There are serotonin receptors throughout the GI tract, as well as what we call the gut-brain axis, which play a role in nausea, vomiting, as well as some pain conditions. And then there are also fatty acid binding proteins. And these are proteins which are responsible for actually capturing these both the plant-based cannabinoids as well as our natural endocannabinoids. So therefore, they play an integral role in how our endocannabinoid system interacts in our GI tract. So this slide, I don't want this slide to confuse everyone. This is a very complicated graph, but there are a few things that I want to relay to the audience. That is that there are several diseases that we've we've found now in the GI tract, which have alterations in our natural endocannabinoid system. Now, whether that is a result of, it's kind of the thing, what came first, the chicken or the egg? Are some of these endocannabinoid system components altered because of the disease, or are they actually causing the disease? We have evidence to support both. But what I want to point out on this graph, if you look at this table, if you look on the left side of the table, you'll see some compounds there that are highlighted and circled in red. Now, those are components of our endocannabinoid system. You'll see we have ligands such as the AEA, which is anandamide, which is one of our natural endocannabinoids. So think about that as the equivalent of a plant-based cannabinoid like THC or CBD, as well as another natural endocannabinoid, 2-AG. And then we talked about the receptors, the CB1, CB2, and TRPV receptors. And then we also have metabolic enzymes, which are responsible for either breaking or for synthesizing our natural endocannabinoids. But then we have enzymes known as FA and MAGL, which are responsible for breaking down our endocannabinoids. And if you look at the top of this table, you'll see some conditions that are circled in green, such as diverticulitis, celiac disease, irritable bowel syndrome, inflammatory bowel disease, which compromises ulcerative colitis and Crohn's disease, but also colorectal cancers. And what I want to point out then is that I've circled some of things that I think are relevant. I tried to stick to just circling things that have been done in human studies. But for example, we can just start at the top left of this corner. If you look at something like diverticulitis, celiac disease, which is an insensitivity or an allergy to gluten protein found in lots of bread and wheat products, that we find that patients tend to have higher circulating levels of our natural endocannabinoids. And of clinical relevance is if you look at things like IBD, which is inflammatory bowel disease, you can see that there are alterations in the natural endocannabinoids as well. But we also see that these diseases are also associated with changes of the receptors themselves, as well as the enzymes that break them down. So this gives us a great opportunity and ability to study this further. And this is actually where some of my clinical research is coming in, where we are looking at some predictors. We're trying to find some predictors of disease and inflammation, looking at some of these alterations in the endocannabinoid ligands, as well as the receptors and the enzymes responsible for breaking them down. So let's talk about cannabinoids and intestinal motility, because this is one of the biggest reasons why we are pursuing cannabinoid therapy. As a general rule of thumb, I'll say globally, cannabinoids can be seen as decreasing GI motility. And this has been proven in both animal and human models, where if you take an agonist is something that will bind to a receptor. And if you do that and you bind these to the cannabinoid receptors, and they've shown in human and animal models that there is a decreased transit time of the stomach, small intestine, and large intestine. And on the opposing side of that, if you take an antagonist, which will actually block these receptors, we've actually seen that this will speed up GI motility. And this motility appears to be primarily modulated through the cannabinoid type 1 receptor. And with respects to some of the cannabinoids, we have seen that THC and to a lesser degree CBN have been shown to decrease GI motility. Now, when you look at motility, also, let's talk about the CB2 receptor now. The CB2 receptor itself does not directly affect GI motility. However, one thing that is important is that the CB2 receptor has the ability to affect motility in diseased conditions. We have learned that in models, in animal models, both in vitro and in vivo models, we have found that if you take a model of inflammation, that the CB2 receptors will actually become upregulated, and the activity of them by cooling off, if you will, the inflammation, have actually been shown to actually then not only decrease the inflammation, but as a subsequent will actually decrease motility. So the CB1 receptor is very important in normal conditions and disease states for motility, where the CB2 receptor appears to be more relevant in disease conditions, which a lot of our patients have. And specifically, CBD and CBN have been shown to decrease motility in inflammatory models. So all of this has relevance for us as healthcare providers, as well as just wellness providers, in considering different diarrheal conditions, irritable bowel syndrome, inflammatory bowel disease, something called short gut syndrome, where people may have had surgery on their intestines so they don't absorb as well. Different constipation conditions, as well as gastroparesis, which is a condition where the stomach doesn't empty, and then, of course, all the things that can cause nausea and vomiting. So generally speaking, just kind of summarize cannabinoids and intestinal motility. If you activate the endocannabinoid system, this tends to decrease motility of the GI tract. Whereas if you inhibit the endocannabinoid system with something like an antagonist, this will increase intestinal motility. And this has been confirmed with the endogenous cannabinoids, which are our own natural cannabinoids, as well as the plant-based cannabinoids, but also with synthetic cannabinoids as well. Next, let's move on and talk about cannabinoids and stomach secretion, because you may read or come across a lot of stuff about cannabis's ability to affect people that have upset stomach from acidic conditions, but also reflux. And right now, we believe that most of the studies support the fact that cannabinoids tend to decrease acid secretion. There's a little bit of mixed data on this, but as a whole, as researchers and scientists in this field, we believe that globally cannabinoids will decrease acid secretion. And we've seen animal models that cannabinoids have decreased gastric acid production, but then also that activation of the cannabinoid type 1 receptor has been shown to be protective in gastric ulcer models. And this appears to be mostly through activation of the CB1 receptor on what are called our vagal afferent nerve pathways. And so clearly this has considerations for patients with gastritis or esophagitis, which is most people who just walk around with an occasional stomach upset, peptic ulcers, gastroesophageal reflux disease, as well as irritable bowel syndrome. Going hand in hand with gastric acid production, we have to also talk about reflux disease. Now, there are two main components or underlying factors which predominate gastroesophageal reflux disease. And what gastroesophageal reflux disease is just the symptom that people experience when the acid from the stomach makes it up its way into the esophagus. I'm sure several have experienced that from time to time. So, and what can cause that reflux is a relaxation of what's called the lower esophageal sphincter muscle. There's a muscle located at the end of the esophagus, right before the stomach, whose job is to stay contracted, so that way acid and food cannot come back up into our esophagus. And what we have found is that this appears to be mediated by vasovagal reflexes, and that this reflex mechanism appears to be blocked by activation of our cannabinoid type 1 receptor. So we have some relatively mixed data on this, but I think some of the most compelling and supportive data for the use of cannabinoid therapy for reflux disease is that it's been shown that chronic cannabis users not only tend to have lower acid tones, but they tend to have higher tones of their lower esophageal sphincter muscle. So if you can find a way to provide a therapy that not only decreases acid production in the stomach, but also diminishes the ability of that acid to enter our esophagus, then that's a great treatment modality for somebody who may have reflux disease. Now, going against that is that if you look at a synthetic molecule called rimonabant, which is a CB1 receptor antagonist, so it blocks that receptor, this is also shown to increase tone of the lower esophageal sphincter. Now, this was an isolated study, and I think that this really points to the complexities of dealing with cannabis, which contains multiple compounds, all the different cannabinoids, terpenes, flavonoids, any sort of additives that go into any formulation. and how those are very different than isolated molecules like rimonabant, which is an isolated CB1 receptor antagonist. But it is generally believed that an increase in our cannabinoid tone might be useful for the treatment of reflux, esophageal motility, as well as disorders, other motility disorders of the esophagus. Moving on from acid secretion and reflux, we'll talk about general overall fluid secretion in our intestines. And intestinal alterations in intestinal fluid secretion are responsible for a lot of the medical conditions that we see in our gastroenterology practices. And overall, CB1 and CB2 receptor activation tends to decrease intestinal fluid secretion. Once again, we've seen this in animal models, in the fact that activation of the CB1 receptors has shown decreased activity of the nerves, of the pathways in the intestines, which are responsible for intestinal secretion production. And in vivo, we've seen that in our natural endocannabinoid, anandamide, as well as cannabinoid receptor agonists have been shown to decrease intestinal fluid secretion in response to cholera toxin. And this goes back to why in the 19th century, cannabis was found to be clinically effective for people who had infectious diarrhea. And THC in and of itself has been shown to increase water absorption. So this all points to the idea that if by activating our endocannabinoid system, you have the ability to alter intestinal fluid secretion. And although human studies certainly are needed with regards to this, there is some current evidence that supports that decreased intestinal fluid secretion does occur with activation of our cannabinoid receptors. And this is very important for the conditions that we treat and that so many people worldwide suffer from. Clearly, if you have too much intestinal fluid secretion, this can cause diarrhea. If you have not enough, that can cause constipation. And if you have irregularity in secretions, then this can lead to irritable bowel syndrome. Next thing, let's talk about cannabinoids and their ability to affect intestinal pain. And that's what we refer to as visceral sensation. The intestines are considered a visceral organ, so it's visceral sensation. And there have been several studies that have proven effects of cannabis for pain. And primarily, this is through activation of our cannabinoid type 1 receptors, as well as our TRPV receptors. And it is these receptors and the way that they act not only within the GI tract themselves, but also throughout our entire nervous system, which is obviously responsible for the conduction of and transmission of pain signaling. And the CB2 receptors, as I mentioned earlier with inflammation, appear to be more relevant in disease states. Now, again, looking at animal models and intestinal pain, they have found that crude cannabis extracts containing CBN and THC all were found to decrease pain at relatively low levels, particularly lower levels, which may cause some of the intoxicating or unwanted side effects from pure THC administration. There's another cannabinoid which is gaining continued interest called THCV, which I think is going to be much more beneficial on the metabolic side of things. But one thing worth noting is that there is some very early concerns that THCV could potentially worsen intestinal pain due to its ability to antagonize or block the C1 receptors, but that hasn't been fully elucidated yet. So if you look at pain as a whole, we don't have lots of great clinical human studies on GI-associated pain, but if you look at pain as a whole, the National Academies of Science, Engineering, and Medicine in 2017 put out a very comprehensive, I think it's a very well done review article looking at this particular topic with regards to cannabinoids and its use for pain. And in that, they looked at 28 randomized controlled trials. So these are, high quality trials. They looked at 16 quality systematic reviews, in addition to 21 primary research articles. They did not comment, they did comment, but there were varying routes of administrations and products, and they also treated lots of different diseases. But their conclusion from from all the data is that there is substantial evidence that cannabis is an effective treatment for chronic pain in adults. And there's no reason to believe that this isn't going to translate into chronic pain for patients with pain from GI conditions. And clearly this is relevant for patients who experience pain from irritable bowel syndrome, cancer pain, and other chronic abdominal pain syndromes. Next, looking at cannabinoids and intestinal inflammation. Again, CB1 and CB2 receptor activity is very important for the modulation of intestinal inflammation. And we've seen through experimental, again, these are preclinical, predominantly animal models, that intestinal inflammation has been decreased with several different cannabinoids, including THC, CBD, CBG, as well as CBC. And this works by multiple different actions, but it has been shown that these cannabinoids have the ability to decrease inflammatory mediators, which these inflammatory mediators drive further inflammation, and that they've also been shown to inhibit reactive oxygen species. Now, reactive oxygen species occur naturally throughout our body, but too much of them can actually cause damage to the DNA of our tissue. And CBD in and of itself has been shown to inhibit nitric oxide synthase, thereby decreasing reactive oxygen species, but that CBD, also keeping in mind that CBD in and of itself has also been shown to have antioxidant properties. And if you look at motility disorders associated with inflammation, inflammation as a whole will generally increase motility, which is why people who have diarrhea, have infections, they get diarrhea because it causes inflammation. If they have inflammatory bowel disease, ulcerative colitis or Crohn's disease, this causes inflammation, which will therefore increase motility. But this concept is important because it crosses multiple disease states, such as inflammatory bowel disease, celiac disease, infections, as well as just general environmental allergies. So when you look at cannabinoids, inflammation, and motility, activation of the cannabinoid receptors tends to decrease the hypermotility associated with inflammation. And we've seen this again in preclinical, in vivo, and in vitro studies. One thing that I think is worth pointing out is that looking at some of these cannabinoids individually, CBN has been shown to decrease motility of the intestines regardless of whether there's inflammation, whereas CBD and CBC has been shown to decrease the motility in inflamed tissue. And so again, I think that's an important point for us to keep in mind, particularly for those who are looking at formulating products or looking at research down the road in ways to affect some of these conditions. The cannabis is used for nausea and vomiting is also certainly not new. As I mentioned, we have Marinol, which is a synthetic cannabinoid called dronabinol that we've been using for chemotherapy-induced nausea. And this was really driven out of the need, and this was driven by patients, and there were patients who were reporting that that cannabis worked very well. However, given the fact that cannabis was illegal, the pharmaceutical industry decided they needed to do something, so they created this synthetic molecule which worked. The problem with that, with dronabinol, as with most other pharmaceutical agents that we have, a lot of these tend to block serotonin or neurokinin receptors. But a lot of the problems with these conventional pharmaceuticals that we have is that they tend to be very good at preventing vomiting, but they tend to be somewhat lacking in their ability to decrease nausea, this anticipatory nausea, which is oftentimes very unpleasant for patients. Of course, it's not pleasant to vomit, but it's also the feelings of having to vomit are also extremely undesirable for patients. And the cannabinoids have shown benefit for their ability to affect both nausea and vomiting. And THC and CBD appear to do this by interacting with our cannabinoid type 1 and type 2 receptors, our serotonin receptors, as well as our TRPV receptors. And again, the National Academy of Science and Engineering and Medicine in 2017 put out a concluding statement that there is conclusive evidence that oral cannabinoids are effective antiemetics in the treatment of chemotherapy-induced nausea and vomiting. Inflammatory bowel disease is a big topic. And again, as most of these topics that we've covered, we could spend an entire presentation talking about all of them individually and the science around them, but I just want to share with you some highlights here. Inflammatory bowel disease is very prevalent. Approximately 3 to 4 million people, now this is in the US, are diagnosed annually with Crohn's disease or ulcerative colitis. So when you're dealing with whenever you're looking at therapies, the first thing you need to ask is, what is the opportunity? And so clearly with inflammatory bowel disease, there's a large opportunity. It is estimated in some of the larger studies, that about 10 to 12% of patients with inflammatory bowel disease report using cannabis for their condition or their symptoms. There's been studies as high as 50%. And in our practice, we have close to 50% of our inflammatory bowel disease patients who use cannabinoid therapy to some degree. About 25% of them incorporate THC, and another 25% roughly tend to stick to non-THC products for various different reasons. We do have some human studies on there. If you look at a lot of these are questionnaires and prospective or in some prospective studies. But the questionnaires that we receive, most of them, some studies conducted and reported in 2011, 2012, have reported improvements in pain, quality of life, depression, disease activity, as well as improvements in weight gain with the use of cannabis. And also, if you look at a lot of these studies, there are several patients who report complete remission, decreased medication use, as well as decreased need for surgery. This was one of the larger studies published in 2019, where they looked at a database of 6,000 patients with Crohn's disease, a large number of patients, and they split them into half who were cannabis users and half who were non-cannabis users. And the patients who were cannabis users had lower rates of cancer. They had shorter hospitalization stays, which were associated with decreased cost, decreased need for IV nutrition, and lower rates of anemia. And in that same study, they also analyzed over 1,400 patients with ulcerative colitis, and half of which were cannabis users and half were not. And of the patients with ulcerative colitis, the patients with cannabis users reported lower infection rates and also lower hospitalizations and decreased costs. So, this has, significant public health implications too, when we talk about, cannabis, particularly when you're talking about decreased costs, decreased hospital stay, decreased need for other therapeutics. I want to share with you a little bit about irritable bowel syndrome. This is a very broad category, but it is actually the number one reason. It's the most prevalent diagnosis made by gastroenterology practices, certainly in the US and I believe worldwide as well. And irritable bowel syndrome it makes it tough because oftentimes it's a diagnosis of exclusion. We rule out other things, and then based upon their symptoms, we categorize them as having irritable bowel syndrome. And irritable bowel syndrome is marked by changes in intestinal motility. So these patients can either have diarrhea, constipation, or they can alternate between diarrhea and constipation. That's what we call mixed irritable bowel syndrome. And these patients can experience abdominal pain, bloating, gas, lethargy, and emotional irritability. And although the etiology of irritable bowel syndrome is not fully understood, there are things that we have learned. One is that there are alterations in the immune system of patients with irritable bowel syndrome. Oftentimes they will have abnormal bacteria, which we call dysbiosis. Patients will frequently have low levels of inflammation. And we've also seen that there are genetic variations in patients there's also that there are genetic variations in patients who have irritable bowel syndrome. And an example of that is patients who have irritable bowel syndrome have been found to have the increased TRPV receptor. So clearly there's some play with that, but that also points to a therapeutic target. We've also seen that there's polymorphisms of the gene that encodes the cannabinoid type 1 receptor in patients with irritable bowel syndrome. With regards to treatment of humans, we do have randomized controlled trials that have shown some subjective benefits, including decreased abdominal pain, decreased frequency of bowel movements with, and most of these studies have been with the synthetic cannabinoids, but we're trying to translate that into cannabis-based therapies. And I will tell you from an anecdotal experience, this has been one of the biggest benefits of cannabis is treating patients with irritable bowel syndrome. And when you look at irritable bowel syndrome, I like to discuss this. I also like to talk about this in terms of what is very interesting to me, and that is this idea of endocannabinoid deficiency syndrome or clinical endocannabinoid deficiency. And if you look at some particular diseases such as migraines, fibromyalgia, and irritable bowel syndrome, they tend to have several commonalities and symptoms with them. Like, so for example, these patients will frequently all have problems with their intestines. They frequently all will experience headaches from time to time. They will also have fibromyalgia or fibromyalgia symptoms. And there's data that is linking a lot of these conditions to alterations in our natural endocannabinoid system and what we call endocannabinoid tone. So, a lot of these patients are found to have low endocannabinoid tone. I also want to talk briefly just about cannabinoids and colorectal cancer, because this is something that is talked about, but I need to shed some clarity on it. And I want to start by giving a disclaimer and emphasizing that pretty much everything that I've been talking about today, although we have a lot of data on this stuff and we continue to get more and more data, the majority of this data is in preclinical studies. And what that means is that it's not done in humans, it's done in tissue cultures of cells, it's done in some animal models. And that doesn't always correlate with the outcome that we may see in humans. Having said that, we are seeing, that it's promising that if preclinical results are showing promise, then next step is going to be to convert that into translational studies in humans. But what we have, I want to share with you some things that we have learned about cannabinoids in colorectal cancer. And the first is that in individuals who have colorectal cancers, we found that there is differential expression of components of the endocannabinoid system. And I point you back to that table earlier on in the presentation. But preclinical studies have taught us that cannabinoids might have a beneficial effect on colorectal cancers. One of the ways they may do this is by inducing what we call apoptosis, which is death of cancer cells. It may also do this by decreasing tumor growth by slowing down what we call angiogenesis, which is the creation of new blood vessels. But the mechanisms by which cannabinoid therapy may benefit colorectal cancers appear to be multifactorial, but we certainly can't comment and make any definitive claims yet. So over the next few slides, I just want to leave you with some concluding remarks. And one is that the endocannabinoid system signaling is very active in the GI tract. And, we would be foolish not to continue to pursue this, the science of it, but also its ability to affect different GI diseases and also how the plant-based cannabinoids can assist in that. The endocannabinoid system plays a role, as we covered, in the balance of a variety of functions in the GI tract, including acid secretion, motility, intestinal fluid secretions, inflammation and immunity, tumor surveillance and protection, as well as metabolism, which again, we're not discussing during this part. The endocannabinoid system does appear to play a very significant role in combating GI illnesses, whether it be controlling inflammation or fighting infection or surveying against cancer. There are genetic alterations in the endocannabinoid system, which may be responsible for some of the GI illnesses we see, and that the components, as I pointed out again, of the endocannabinoid system are very variably expressed in patients with different GI conditions. Several patients do report improvements in disease, symptoms, and quality of life for numerous GI conditions with cannabis. And cannabinoids have been proven to provide pain relief through interaction with cannabinoid receptors. The phytocannabinoids, including THC, CBD, CBC, CBGN, CBN, and THCV, and of course many more, we do know influence the endocannabinoid system of the GI tract. And these influences have proven benefit in some things like nausea and vomiting and pain conditions. However, preclinical data, which is promising, showed that it might affect a lot of these other conditions as well: inflammatory bowel disease, reflux disease, irritable bowel syndrome, cancers, obesity, and metabolic disorders. Preclinical data on cannabinoid therapy for GI conditions is promising, but there are several unanswered questions. Many patients with GI conditions will benefit and can benefit from cannabis therapy. A large amount of our data is anecdotal. However, in-depth research has begun to help us understand the pharmacological actions of these individual cannabinoids. It's also important to keep in mind that there are significant risks and side effects associated with a lot of the conventional pharmaceuticals that we use for GI conditions. And although cannabis also has side effects and safety concerns, these appear to be at least be comparable, if not mostly favorable relative to conventional pharmaceuticals. So as far as future directions, some things that we need to answer. Number one is which cannabinoid and terpene formulations are most beneficial and what are most beneficial for particular conditions. Which routes of administration and delivery systems are most effective. We have to learn more about dosing. And another area of interest of mine is genetic variations from individual to individual and how different cannabis formulations and pharmacology can affect outcomes. And also, part of the problem with some of the side effects of cannabinoids, particularly THC, is their ability to affect centrally and cause people to have that euphoria, that high, that dizziness, or maybe some unwanted side effects. And so we're looking at cannabinoids as well as other cannabinoid-like compounds, which won't cross the blood-brain barrier, so they'll just work peripherally. So therefore, it has the potential to minimize a lot of the unwanted potential side effects. So I will conclude there, but again, I want to thank CBD Live. I want to thank all of the participants for joining us. I think at this point in time, again, I want to point out that my contact info is there. Feel free to send me, an email or reach out. At this point in time, I'm going to try to see if I can sort through some questions, as I think we may have just a few minutes here. And one of the questions was, what was it that made me think about getting into medical cannabis field? And that was that's a great question. It took me about 5 to 7 years to admit to my family that I was involved in medical cannabis for my patients, but I learned from my patients. When patients came and would tell me, listen, doc, I appreciate these medications you've been prescribing for me, but I have to be honest with you, I've not been using it. I've just been using cannabis. And when I see the fact that they're clinically doing well, that their quality of life is improved, that they were coming back to the hospital less, that they were being operated on less, that spoke for itself. And these were not people who were looking to use cannabis recreationally. These are people who needed it for their quality of life, everything from doctors to attorneys to professionals. Great question. Let me just sort through some of these other questions. What are your thoughts? I have a question here. What are your thoughts about the UK legalizing this for patients with GI disorders? I can't speak to all the legality in the UK right now, but I will tell you that in the US, this is one of the biggest indicators right now. So there's be no reason that the UK should not follow suit, as there is enough data, I believe, to support its use. A question came from one of the guests about how might you raise the idea of cannabinoid therapies with my doctor, and where do you start? That is another great question, and some of that comes down to every provider is going to have a preconceived notion about cannabis. It's either going to be very positive, very negative, or it's going to be neutral, saying they don't know. I always find it's, I've had to talk to patients to relay this information to their medical care providers, and I will typically provide them with some sort of information first. I will encourage them. Fortunately, they're welcome to come to me first, and I can give them information on it to present to their provider. But it never hurts to ask your provider first and foremost, what is your thought on cannabis therapies for whatever condition? And if they tend to blow it off, then it means, or ignore it, then it means that they probably haven't been educated on the science of it, or they have their own personal political feelings of why it shouldn't be happening. But you don't know until you start raising the question and point them to 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 some science, and if not, find another provider who may be more open to the idea. um, I have a question here that what would you recommend for someone who has Crohn's disease but has never tried cannabinoids before? Well, some of that is going to be depending upon what sort of access you have. If you have access to THC-based products versus non-THC-based products, you have to ask yourself that question first. I tend to always try to work with patients first who utilizing non-THC, because there's lots of concerns about THC, whether it be for some of the adverse effects, also for some of the legality of it. But we cannot ignore THC. I mean, THC to this date is still one of the most important therapeutic applications we have, of cannabinoids. And when you look at that, from a Crohn's standpoint, I have, you have to ask the question of why is somebody with Crohn's taking it? Are they taking it for symptom relief, or are they taking it to really control their disease? And they're very different. People with inflammatory bowel disease, some have very active inflammation, and they can have severe diarrhea, but also rectal bleeding. That's very active inflammation. And when that inflammation is that bad, we typically find that a combination of THC and CBD with the other minor cannabinoids are more beneficial than any of them in isolate. However, people who have very mild symptoms, I tend to start them out on, a non-THC product at a lower ratio, a lower, or something with a very low level of THC in it, and start to work with them on that. And there's also a question that came in on celiac disease, and for all intents purposes, celiac disease is not much different, except for the fact it's not, as strong of an autoimmune condition as Crohn's disease or ulcerative colitis is. It's more of an environmental food allergen, if you will. But the same concept and principles apply. When you have inflammation, you have pain associated with it, you have diarrhea, and the cannabinoids can all assist with that. One of the questions, one of the last questions here, says, if THC helps with water absorption, could this help with water retention? We don't see that people who consume THC tend to gain weight as a result of overall fluid absorption. It tends to be more at the intestinal level. So it should not affect in a negative way. However, in patients who have diarrheal conditions, or they have short gut syndrome where they just can't absorb enough, THC can be helpful to not only slow down the motility, which will give the gut more time to absorb water, but THC in and of itself will also absorb water. There was a question here about Coral Cove. Coral Cove has been active for a while now, but we are redoing it, an entirely new model. If anybody is interested in Coral Cove, right now our website will be revamped here in a few days. But in the meantime, please feel free to reach out to me via my email here at aabadili@reservemdhealth.com, and I will get anybody plugged in and interested who might be interested in learning more about Coral Cove. But like I said, it's really going to be an exciting opportunity, really an international hub for people to learn about all things natural-based medicine and cannabis-based and psilocybin-based. But just a beautiful place to come and relax and enjoy some, high quality medical grade cannabis in a very wellness and health centric resort and retreat. I'm not seeing any other questions. I will leave it up to the host dismiss us when they feel it is ready. But if there are no other questions, I will just wait. But it's been a pleasure virtually speaking with you, and I look forward to networking with those that have participated in this event. So thank you very much, and again, thank you to the CBD Live.